Good evening, everyone, and welcome to this Thursday webinar, which has been done for a long time from CCI. It's a rather unusual webinar, away from the usual webinars that we've been seeing on CCI. And appropriately, we have a wonderful elite panel here with me who are going to handle these very important areas of pulmonary and cardiac medicine. We're basically looking at auscultatory signs, signs in the pulmonary system, the respiratory system, and signs in the cardiovascular system. And today we are really going to be sticking to auscultation. So we have a panel familiar to everybody in CCI. We're all very well known. We get daily messages from all of these elite CCIans, starting with Professor SK Chhabra from Delhi. I'm not going to introduce them anymore because you all know them. It would be futile to introduce them. So Professor SK Chhabra, who is, one of the most knowledgeable people we all know. Professor Radha Munje from Nagpur, again, not only known for her knowledge, but also that wonderful smile she always gives us. Dr. Nitin Abhyankar from Pune, who is the master not only in pulmonary medicine, interventions, but also in writing poetry. And he writes some brilliant poetry in Marathi, translates it into Hindi. And I have the pleasure of Google translating it into English sometimes. And Dr. Tridib Chatterji from Bombay. So we've got people from all across, all active CCNs and all active academics who teach postgraduates every day. We have one cardiologist, Dr. Saket from Patna. Thank you so much for joining us. Whenever I've been in a panel, and I'm often in a panel with the cardiologist because my interest is pulmonary hypertension predominantly, apart from ILD. So I'm often in a panel with cardiologists, and I feel very, very lacking in confidence sometimes when this happens. So I understand how you must feel, but cardiologists are known for their confidence. So I'm sure you'll be fine. And you're the only one who knows anything about cardiac auscultation here. So welcome, Dr. Saket.
Thank you, sir.
Why are we having this, this webinar on physical signs? Because in this day and age, how often do people really bother about physical signs? What is their relevance when we have advanced investigations? We have the best of investigations in the form of not just the X-rays, but CT scans, MRIs, cardiac MRI, echocardiography. We have various pulmonary function tests. And now we are adding on artificial intelligence to all these. So what really is their relevance? So I'm going to very briefly talk about what is the relevance still of physical examination. And then we will go to these physical signs with our elite panelists. You may hear some weird sounds in between. Forgive me. These are there's some work going on at home and I'm unable to keep them quiet. So please forgive me if, you get some odd noises in between. So let me start. Why this topic, first of all? Is clinical examination relevant in this era of advanced investigations? So there was this nice article published from the Royal College of Physicians Journal, which spoke about 7 reasons why physical examination is still relevant. First of all, it contributes to the diagnosis. And we know that a good history and examination contributes to the diagnosis somewhere between 70 and 75% of the time, even without getting into the most basic investigations. So clearly something that contributes to 70 to 75% of the diagnosis is extremely important. The second is it tells us about the prognosis. We know, and we can do these tests every day, physical examination, whereas we cannot do echocardiograms and MRIs every single day. So today, if you come and see a patient who yesterday had a clear chest, now has an S3, raised JVP, basal crackles, he's in congestive heart failure. You don't need to do an echo for that. Similarly, in COVID-19, one of the things we all measured was the respiratory rate and the SpO2. And we knew whom we had to send to the ICU, whom we had to send to the ward, whom we could manage at home. I'm hearing a lot of background noise. People who are talking, please unmute themselves. The third is very importantly for patient safety. There are points that you will miss if you don't examine a patient. This particular article that I'm referring to spoke about an 82-year-old man who had a distended abdomen, and all kinds of investigations were done without even looking at his abdomen. He was agitated, elderly person. Clearly, it was just constipation that was causing his problems. So simple patient safety is guaranteed by doing part of an examination. Patient contact is vital, absolutely vital. I will recommend all of you watch a TED Talk by Dr. Abraham Verghese, who's one of my heroes. It talks about the importance of touch, and this cannot be missed. My own chief, Dr. Devi Shetty, is another person who believes strongly in the importance of touch of a patient. We lost this during COVID. We are rediscovering it now, and I think it's extremely important. Touching the patient, I can't say it better than Abraham Verghese, so please watch that TED Talk. 10 minutes, no more. It's very important to teach medicine, and all of us here are either learning medicine as postgraduates, and postgraduates teach medicine to undergraduates. And as teachers, we teach both PGs and undergraduates. So William Osler said the whole art of medicine is in observation, and physical examination is basically observation. It's very important to teach clinical reasoning, and this happens only by the bedside when you're examining the patient. Today, I had a patient who has a variety of problems of small cell carcinoma, an ACTH-dependent metabolic changes of Cushing's, but he also has a right lower lobe pneumonia, and he had classic features of crackles. He had, which Dr. Tridib Chatterji is going to take us through. He had egophony. He had whispering pectoralochi. We don't need to look at his CT to make a diagnosis of infection in this man who already has fever and tachycardia, tachypnea. Very importantly, it reduces over-investigation. So if you look at over-investigation, which is happening these days, there's a whole bunch of reasons why it happens. We're all in love with technology, and we would rather send a patient for a high-tech investigation than examine them. We seem to have too little time to examine patients. A lot of us are fearful of litigation, which is increasingly becoming a problem. And in India, it's not just litigation, it's also assault. We are worried about patient expectations. Patients expect to undergo investigations. I've had patients who come with an MRI, push it at me and say, see, I've got an MRI done. And when I'm trying to examine, they say, I've already got the CT done. You know, it's almost like, why are you examining me? Of course, physician reimbursement, unfortunately, is often linked to how many investigations you've ordered. And this is so in some corporate hospitals, not in all, and I think should be strongly discouraged. But one very, very important reason is clinical skills are in decline. We are in this area of what was recently called in an article, hyposkilia, where people don't have clinical skills. And today's webinar is one of the attempts to try and improve clinical skills overall. Is clinical examination really reliable? And do physicians agree with each other? So one of the things they look at is something called CAPA, where we look at what is the inter-observer agreement. So with a CAPA between, and I'm going to keep coming to this, so please remember these numbers. A CAPA between 0.1 and 0.2 is just a slight agreement. 0, of course, is no agreement at all. We are reasonably happy with a CAPA of 0.2 to 0.4, a fair agreement. A moderate agreement, which all are very happy with, is 0.4 to 0.6. 0.6 to 0.8 is substantial agreement, and between 0.8 and 9 is near perfect agreement. But we'd be very happy with any inter-observer between 0.4 and 1, but even reasonably happy with 0.2 and 0.4. So when you look at what is happening with a comparison of a physical finding and what is a diagnostic standard, you can see that a liver span greater than 9 centimeters by percussion, not palpation, is 0.11, not great inter-observer reliability. But coronary artery lesions after a cath, there's a CAPA of only 0.33. Let's go to clubbing. Physical finding, CAPA is 0.64. Cirrhosis, even on a liver biopsy, has even a lower CAPA, almost the same, but lower. Tachycardia, 0.85, very good. Whereas diagnosis of a narrow complex tachycardia, much less than that. Just looking at an abdominal jugular test, the abdominojugular reflux, 0.92, excellent agreement. Interstitial edema on a chest radiograph, less than that. Both good, but less than that. The point I'm trying to make here is most often, physical examination is just as good as for inter-observer agreement as a more advanced investigation is. Where is the evidence for other physical signs that we are looking at? I'd strongly recommend that everybody read this book called Evidence-Based Physical Diagnosis by Stephen McGee. I think it's one of the finest books that I've read, and I'm going to take quite a few slides from this book for the next part of my talk. So what he talks about is, again, looking at the kappa. When you look at clubbing, there are different ways you can look at clubbing. So if you look at Shamroth sign, it's got an inter-observer agreement of 0.64. But if you use the interphalangeal depth ratio, which if necessary we'll come to, it's as high as 0.98, almost perfect for defining clubbing. Let me go to another one on percussion, because that's what we're talking about today. Physical examination of the respiratory system. Hyperresonant percussion note, very good, to fair to very inter inter-observer agreement. Auscultatory percussion being abnormal, variable. Diminished cardiac dullness, pretty good. Dull percussion note, again, variable, depending on who's doing it and where it's being done. Auscultation, Dr. Tridib is going to be talking about crackles and wheezes. Reasonably good inter-observer agreement. You look at special tests, for example, you look at Wells' simplified rule for pulmonary embolism, which doesn't read very much except a history and examination. Very good inter-observer agreement. On the other hand, look at what when you get a computerized tomography of the chest. Lung cancer staging, just about the same. Submassive pulmonary embolism on an angiogram, CT pulmonary angiogram, less in fact than Wells' simplified rule. So it's very, very important that you look at what is the relevance of physical examination. Similarly, when you go into Dr. Saket's area, if you're looking at the auscultation, you'll find that there's very good inter-observer agreement on all these, whether you're looking at an S3, an S4, a systolic murmur, greater than grade 2, you have excellent inter-observer variability. Let me go to anemia. If you look at pallor at any site, you're not going to get great sensitivity or specificity. But you look at a very good sign like conjunctival rim pallor, it may not be very sensitive, but it's very, very highly specific. And this works quite across races, whereas pallor at any site doesn't work very well for the darker skinned like Indians and people from continental Africa. I'm going to come back to likelihood ratio if necessary, but if this finding is present in the background of a high pretest probability, look at what the likelihood ratio of that condition is. If conjunctival rim pallor is present in somebody whom you thought based on history has likely anemia, then the likelihood that the person has anemia is almost 16 times that. The point I'm trying to make is you need to take into account the history along with physical examination, assess the pretest probability of having a condition, and then decide if this person's physical finding is relevant or not. Here was another from India, from Amrita Institute of Medical Sciences, an excellent pediatric cardiac team led by Dr. Krishna Kumar, one of the ACE pediatric cardiologists. Excellent paper in the BMJ Pediatrics. They spoke about the accuracy of physical examination by consultant versus echocardiography. And you can see excellent specificity and sensitivity, all in the region of 95 to 100 for common conditions like ASD, PDA, VSD, and VSD. With pulmonic stenosis. Okay, the likelihood ratios were all very good. You can see varying from something like 20 to almost 100, close to 200 times the positive likelihood ratio, and the negative likelihood ratio was also very good. So you had a very high chance of picking up a condition by physical examination as compared to echocardiography. And inter-observer agreement, not just for consultants, but between fellows and consultants was also extremely good. So even residents in cardiology were functioning as well, almost, as highly qualified, highly experienced consultants. This is what I was talking about when you're looking at clubbing. How relevant is it when you're looking at a particular condition would depend on not only the test that you use, the index that you use to decide if there is clubbing or not, but also what the condition is. So if you pick up on this is the interdigital depth. If you take the depth at B, that is at the nail bed skin, the skin fold nail angle junction, and compare it to the distal interphalangeal distance in the midline, that's the ratio. If it is more than 1.2, you're almost definitely dealing with clubbing. What is its likelihood ratio when you have hypoxia in a patient with cystic fibrosis? Is almost 3 times. If you're looking at somebody who has features suggestive of infective endocarditis, fever in the background of a cardiac problem, maybe a changing murmur, maybe splenomegaly, the presence of clubbing there increases the likelihood that the person has infective endocarditis almost 5-fold or more than 5-fold. Similarly, in patients with cirrhosis, you and I are interested in, does this patient have hepatopulmonary syndrome? Increases the likelihood if you have clubbing 4.6 times. So physical examination in the correct setting still has extremely high relevance. Breath sounds, I don't want to waste more time on this, but look at the likelihood ratios if this finding is present in the appropriate clinical setting, extremely high likelihood ratios. Detecting pneumonia in a person with cough and fever, if there is bronchial breath sounds, the likelihood ratio goes up 3.5 times almost. Egophony, even better, 4 times. So very important for us to know what is bronchial breath sound, identify it, look for egophony, look for whispering pectoral loci. And as I said, this is the likelihood ratio. If you have a person whose breath sounds are diminished, the likelihood of picking up a pleural effusion is almost 5-fold. Look at vocal resonance, increased chances of egophony, as I said, going up to about 4 times, and diminished vocal resonance in detecting a pleural effusion almost 6.5 times. So in the right pre-test probability, and I keep emphasizing pre-test probability, I'm going to go beyond this because this just says the same thing over and over again, is that you depend on this question of what are the test results, positive and negative, presence of disease or absence of disease, to calculate sensitivity and specificity. You can also calculate the likelihood ratios. But look what happens when you have the pre-test probability, combine it with the likelihood ratio, then you get a much better way of finding out the post-test probability. I think this is something that we all need to take into account, even in physical examination, and it is not restricted just to lab tests as many people think they are. I'm going to stop at this point. Thank you all for this very patient hearing, and stop sharing and hand over to our panel, whom I will be asking questions to. I will first ask Professor Chhabra to take us through, what is normal. Professor Chhabra, can we have you? Yes, sir. What are normal breath sounds? What is the relevance of a stethoscope in picking up normal breath sounds? And something we were just discussing before we came live is it important to have a very good stethoscope? Do you need a high quality Littmann? Does an electronic stethoscope make any difference? So Professor Chhabra is going to enlighten us about the physics and the physiology behind normal breath sounds, and how we auscultate for them, how one uses a stethoscope, and is a stethoscope really important? And I'll invite all panelists to come in after Professor Chhabra has finished.
Thank you, Dr. Murali, and I really enjoyed your presentation, very enlightening, and especially the figures of sensitivity and specificity that you showed for different signs. Clearly, it's very, very relevant. It's something you can't depend on technology every day when the patient is being followed up in your OPD or admitted patient in the ward. So physical examination will be there to stay. And the word that I have read that article about hyposcalia. It is very unfortunate that we have taken that path, and I would strongly urge our younger people in the audience, those who are budding pulmonologists, that they have to revive this art. Somewhere, as technology developed, we are losing this art. In this panel, we are all of that era where we knew the value of the science. So here we all agree that signs are valuable, but mainly for the younger audience, I would say. Now, coming to the questions that have been asked to deliberate upon. See, when we breathe, then the air passes through the nose, down the trachea, to the left and right main bronchus, and then segmental bronchi, and they're almost, depending on the segment, anywhere between 14 to 23, 24 divisions. Now, the air that loses its velocity. So the flow patterns, these change as we go distally. So roughly till about the 8th segment, the flow is fast. So it's what is known as a turbulent flow. After that, as the combined cross-sectional area of the airways increases, the velocity slows down, the flow becomes very, very small, slow, and is called a laminar flow. As air flows through a tube, it will produce sound because there is friction with the walls and the flow itself produces the sounds. Now, when we auscultate, depending on where we are auscultating, we'll get these sounds. So these sounds, these are transmitted from the airways through the lung parenchyma across the chest wall to the surface, from where we pick it up using a stethoscope. A lot of these sounds get filtered out. So what we actually hear is the sound which is filtering out through the lungs. So anywhere we auscultate over the lungs, we'll get a filtered sound, except that when we auscultate over the trachea, then we'll get pure turbulent sound. So if we auscultate over the bases and trachea, we get two different kinds of sound. The sounds over trachea are turbulent. They have a clear pause between inspiration and expiration. These are hollow. So these are the classical example of what are known as tubular bronchial breath sounds. Lower down over the lungs, the sounds are muffled, soft. There is an inspiration and there's an expiration. The expiration is never complete. So we only hear about 2/3 of the expiration. The terminal 1/3 of the expiration is lost because the flow velocity is very, very less there. So the inspiration and expiration ratio normally is 1:2 or 1:3. So our expiration is prolonged, but we don't hear the terminal part. So that is a vesicular breath sound. So these are the two normal breath sounds. Anything extra that we hear, any interrupted sounds or any musical sounds, these are pathological sounds, so which we'll be discussing as we go along. So that is the physiology. It's the rate at which the air is flowing and through which passage, what is the diameter of that passage, what is the filtering of the sound by the lung, that will determine. For example, if there's no filtering, there's solid mass over a bronchus, then the bronchus sound that is directly communicated to the surface. So that is bronchial breath sound because there's no filtering. So that way, depending on the kind of sound that we are getting, we get some idea about the pathology. Now about the relevance of stethoscope. As we have been discussing earlier also, so we need a stethoscope to pick up disease. It helps in diagnosis. So the first slide Dr. Murali showed that examination is very, very relevant to focus our investigations. Now, for example, in dealing with patients with airway disease, asthma or COPD, picking up signs of airway obstruction, that is one skill which pulmonologists have to pick up. And one can therefore focus our investigations that the patient may be having this disease. So that gives us a pre-test probability along with the history. So stethoscope remains very, very relevant. And there are certain signs, and this comes with experience. And when we do auscultation, we should also look at the patient's history and investigations. So that becomes a feedback to a physician, and very often one can make a diagnosis of obstructive airways disease by auscultation. Similarly, idiopathic pulmonary fibrosis, very classical crepitations. So these are very specific signs which experienced observers can straight away say that without any investigation, these are the possible diagnoses. About the type of stethoscope. Now, when we buy any kind of sound equipment, we look at specifications. What is the wattage, then what is the frequency response, the bass, the treble. Unfortunately, for a stethoscope, there are no specifications. Even the branded stethoscopes, they do not have any specifications. And what generally one goes in is for the design as well as the brand name. So any stethoscope which fulfills the requirements, what the stethoscope has to do is it has to pick up the vibrations on the chest wall, conduct it through the tube, and in the earpiece, one has to listen. So most stethoscopes will perform very well if they are not damaged. No point spending too much money on a branded stethoscope, but one should learn to use a stethoscope. There are electronic stethoscopes also, but I think we'll discuss those later. So anything else you want me to add, Dr. Murali? You had asked a few questions.
Yeah, no, I was wondering if you could just take us through the, the relevance of systematic examination, auscultation of the lung, what all one goes through, which are the areas one examines, and in what order one does it, especially when one suspects disease on one side.
Right. So when auscultation comes after we have done inspection, palpation, percussion, so that's the fourth part of the examination. The room must be quiet because we are trying to pick up sounds, and so if there's external noise that will interfere with what we perceive, it is always better to have a warm room because the patient has to undress the upper part of the body that should be exposed because we don't want any interference with external objects like clothes. Examining a female patient, it's very, very important that a female attendant or nurse is there or an attendant is there because one can get into trouble. So that these are very important precautions one should take. And one's own hands should also be warm because you are going to touch the patient. So patient ideally should be examined sitting upright. Patients who are admitted or in the ICU, we can also auscultate in bed. But because we want to have an idea of the entire lung, so sitting posture gives a better exposure of all the lobes of the lungs. The patient is asked to breathe gently, but more deep than normal and always through the mouth. We should take care not to ask the patient to hyperventilate because auscultation is going to take time. If patient is going to hyperventilate, he is going to have a syncope. So that is very important, that deep breaths, but not deep and fast, comfortable so that patient is comfortable and doesn't get a syncope. One goes systematically. So you have to basically auscultate all the lobes and all the segments. So we start with the apex, and because we are trying to pick up pathology, so the order is that we go from above downwards and corresponding areas of right and left side are compared. The disease may be symmetrical or maybe asymmetrical, but it's always a good system to develop that if you are auscultating on the apex, do it on the right side, then on the left side. Infraclavicular, do on the right side, then go on the left side. So we go above downwards. Similarly, in the axilla, so one needs to know the surface markings, that which are these infraclavicular regions, the mammary region, the inframammary region. Then in the axilla and the infraaxillary region, posteriorly, the suprascapular, interscapular, and subscapular regions. So all these regions have to be covered, and one has to compare. And then one listens to the sound. Now, a stethoscope has two parts to it. There's a bell and there's a diaphragm. In lungs, most of the sounds are high-pitched, and diaphragm is ideally suited for lung auscultation. In cardiac auscultation, one uses a bell also, but majority of the time it's only the diaphragm which is used because low-pitched sounds are not very frequent in lungs. So diaphragm is the one that one is going to use. So symmetrical examination from above downwards, all lobes and segments covered, and then we look for the pitch of the sound, the amplitude or the loudness and special characteristics of the sound. And then as we go along, try to make a mental picture that are we getting a bronchial breath sound? Are we getting a sound which is abnormal in one particular region? So that by the time we have finished auscultation, we have a fair idea that this might be the pathology. And then we put together the findings of inspection, palpation, percussion, and auscultation and reach what is known as a physical diagnosis. So this is the scheme of things for physical examination with emphasis on auscultation.
Great, sir. Thank you. I wanted to really go to all the panelists and say, would you all have anything to add on normal examination? For example, it's always, something I emphasize to my students is that when you suspect disease on one side, start with the normal side and then go to the abnormal side. That way you pick up the variation much better. So any other tips from any of the other panelists?
Murali sir, can I add a very small point? Yes, yeah. I think obstructed nose creates a lot of confusion. So very simply, in fact, because many a times a person has a badly obstructed nose, and if he has lips closed and then you're auscultating, we are talking of auscultation alone, then in an asthma-like scenario, you really are not able to make up much. So all you have to do is just tell the patient to open their mouth and then breathe. And then you have those sounds which you really want to listen rather than add-on sounds which from the obstructed nose which are adding a lot of noise. So I think one simple tip for everybody.
Yeah. Breathing is always mouth breathing. In auscultation, is always mouth breathing.
Absolutely.
Yes. Can I add something to that?
Please, ma'am. Yeah.
If this is for we have lots of younger people listening in. So if you put a stethoscope, say at apex, and you hear a lot of sounds, and you are very happy that you are getting something abnormal, I would always suggest that ask the patient to turn the face and cough out first, so that the secretions in the airway are removed, and then you really get the auscultatory findings which would be better interpreted. That's one thing I would like. And second thing I would like to say that Dr. Chhabra has told very well that in which way you should be auscultating the patient methodically, like apex on one side and the other. But to it, can I add that because auscultation comes at the end of the systematic examination of respiratory system, you have already, have done inspection and palpation, and you have a fair idea which side of the chest is probably diseased. So I would always say and suggest that once you have a fair idea, auscultate on normal side first and then on the suspected affected side, so that the findings are better appreciated in terms of interpretation.
In fact, this is true for all findings, isn't it, ma'am? Even when you're percussing, you have an idea which is the abnormal side from the inspection and palpation, or even from the history. You always start on the normal side and then go to the suspected abnormal side. And that's extremely important. The other thing that I always, Professor Dr. Tridib, I'll come to you very soon.
No, good, please.
Other thing I always say is, Dr. Nitin Abhyankar made this very important point. I've always seen, if you ask a patient to breathe, many patients will do like that, and that completely messes up your examination. Okay, because you're not getting anything like natural. I find it simpler to just not even tell the patient, auscultate when they are breathing normally. If you can get up and get enough findings, wonderful. Then you start to ask them to take deeper breaths. If you start by telling them to take very deep breaths, very often you get into trouble. So start normal breaths, open mouth, then move on to deeper breaths. And, if the person breathes very hard, as Professor Chhabra said, they end up with a very dry mouth and with dizziness, and that is not conducive to the rest of the examination. Because as Sir said, the patient is sitting very often. Ideally, do it in a sitting position. If the patient is lying down, make sure that you auscultate both bases, because especially in a lying down patient, a patient of the ICU, findings are often at the bases. And we auscultate the front of the chest and neglect the more relevant back of the chest. Extremely important. Dr. Tridib, and then we'll come to Professor Chhabra.
I just wanted to add one point that when the turning of the mouth, maybe for your own safety also, it's better you turn that pushed pan. You may be wearing a mask, but he may be a COX patient. So for your own safety also, that would be useful. Just wanted to add to that.
One of the things I've started doing post-COVID is standing behind the patient and putting my stent in front of the chest, of the patient. So the patient is not breathing into my face. So that's in the sitting patient, becomes easier. Sometimes you're not able to do that in the ICU when the patient is at the back. And just yesterday, as you were saying, we have this influenza A positive patient on an NIV, and the entire exhaled air, the expiratory flow is coming into my face. So that's a very important point you made, Dr. Tridib. Stand by the side, turn the patient's face away, or stand at the back and auscultate over the shoulders when you're auscultating. Go to Dr. Chhabra and then come to Dr. Nitin.
Yeah,
Sir, do you wanted to say something?
Yeah.
I was reading about the history of development of stethoscope, and the main reason why it was developed was hygiene.
Exactly.
That was the reason. Otherwise, they used to put their ear on the patient's chest.
And then hands, right.
Now, a word about the flow of the different components of examination. We are used to this inspection, palpation, percussion, auscultation routine, but this is a long case routine and examination. Something which we don't use in our practical day-to-day. So very often one would straight away go to auscultation. So one has to learn the art of, at the same time, doing inspection also and percussion also while we are auscultating. Because in an OPD, it's just 2 or 3 minutes of examination. So that is okay to talk of a long case, 4 components, but here inspection, auscultation, everything goes side by side.
Absolutely right, sir. I mean, you can't be doing the systematic examination in every single case when you have 40, 50 patients sitting outside, desperate to come in. Absolutely right, sir. Dr. Nitin, you wanted to say something.
Yeah. I think I absolutely agree, and then take it a little forward from Dr. Chhabra. I mean, we are doing inspection and then auscultation, or rather inspection and auscultation hand in hand. More importantly, what about the video consultations? Because so many of us claim today that we have done wonderful video consultations and thousands of patients have benefited, or rather hundreds of doctors have benefited. I don't know which of the two is true. So I very frankly find that, auscultating at the right time, with the right purpose, with the right clinical history makes all the difference. And not auscultating at the right time, despite the right purpose and despite all the data pointing towards, okay, I'm expecting, the obstruction, and then I'm looking for those rhonchi or whatever I call it, or I'm expecting basal rals and I'm not looking for them. I'm not able to auscultate. Doesn't that leave my examination half-hearted? And of course, I mean, that may bring in eventually the electronic stethoscope and whatnot. I've played with it, but I don't find it as useful as actually doing it myself, very frankly. So I tried all the methodologies of doing a video consultation, couldn't agree with it during COVID. Despite getting it COVID twice, I still continued doing the normal way of doing normal examination. I know it's not 100% perfect, as Dr. Chhabra keeps saying that, that we are not doing the inspection, observation, percussion, auscultation in that order, never. But even those 2-3 minutes give a lot of psychological benefit to the patient and a clinical benefit to the patient, both together.
So
if
I think we
done
are
correctly with a correct story and correct interpretation of it.
I think we're running out of time. I'm going to request Professor Radha Munje to tell us something about, breath sounds, abnormal breath sounds, bronchial breathing, and so on, before we come to, and I'm just wondering if we can take a break. We've got a guest here, Dr. Saket. We shouldn't try his patience by making him wait too long. We'll come to Professor Radha Munje, and then we'll go on to the cardiac part of it, and then come back to the rest of the respiratory examination.
No, Dr.
With the
Munje,
permission
I
of
can
all
even
the
wait
panelists.
for 2 minutes. It's no issue. I think, in fact, Saket, Dr. Saket can come in at this time and drive away the monotony if you want. I can wait, or else I can go ahead with bronchial breathing.
We'll go ahead with yours, ma'am, so we don't have a break. Then we'll come back to the added sounds and so on. So we'll start with you, then we'll go on to Dr. Saket.
Okay. So we were talking about the abnormal sounds and the types of breathing which I would be telling you. So when we talk about, Dr. Chhabra has already explained so well about the sounds which originate from the mouth and then they go down. So earlier the air passes through the tubular airways. They are tube-like structures, let me say. And then the sound gets, the pitch gets lower and lower because a vesicular component gets added to that. So what you say when you talk about breath sounds are that whenever you auscultate over the parts of the lung, then it is a vesicular breath sound, because the sounds which are produced get, what do I say? They get modified as well as damped down because of those alveoli or the vesicles which they have been termed, and that is why it's a vesicular sound. Then when we talk about the bronchial breathing, as Dr. Chhabra has already said, that the sounds first are produced in the trachea, where the airflow is occurring and the air is going down. So the tracheal sounds, if you will auscultate, it represents the quality of bronchial breath sounds. But we call tracheal sounds as tracheal sounds only. It's not termed as bronchial breathing. However, lower down when you auscultate over the areas of the lung, and at that time, if these sounds are similar to the sounds which are produced over the trachea, then you term this as bronchial breathing. So what type of sounds are these? So if you are auscultating a person and you comment that this is a vesicular breathing, what is it? That the inspiration is long to the tune of at least double of the expiration. Expiration is short and there is no pause in between. Whereas whenever you talk about bronchial breathing, what is happening is that the inspiration and expiration are almost equal. And there is a gap between the inspiration and the expiration. But this is not so, because what I have observed that if you are auscultating a patient, you may not be able to make out the gap. Then what is important to qualify a sound to be a bronchial breathing is look at the pitch. So what is it is, in small words, it is the frequency with which the sound waves are traveling. And higher the frequencies, higher the pitch. And that is what is a high pitch sound, which we term as bronchial breathing. And this would also characterize, I always explain to my students, and I would like to take this opportunity and try to explain it the way I do every time, is that whenever, what do you need to hear a bronchial breathing or even the breath sounds? Three things are needed, like the sounds are being produced in the airways and they are being now conducted down. So what you need is patent airways from where this air is flowing and the sounds are being conducted. Then the second important thing that you need is the medium between the airways and your stethoscope. If that medium is conducive to conduct the sounds, then only you will hear these high-pitched sounds, which you term as bronchial breathing. Now, let us take an example of the classical case where we hear a bronchial breathing, and all of us know that this is a case of consolidation. So what happens in the consolidation is that these alveoli are not only filled with exudates, but these are not, in all probabilities, not liquid exudates, but they try to solidify the alveoli. So what happens is that there is something solid, and inside it, the airways, or what you usually see radiographically, The airways are patent. They are not filled or obstructed. They are patent. So the sounds produced at the tracheal levels are easily conducted from the airways through the medium which is solidified or the consolidated lung, and then you can hear it with your stethoscope in your ears. So this is what I think is important whenever the sounds are being conducted. So whenever you comment upon breath sounds are absent, what is happening is it's not that the breath sounds are not being produced. It may not be also that it is not being conducted in the airways, but what has gone wrong is the medium between those patent airways and your stethoscope. That is not conducting the sounds. So I think this is one has to understand about a classical tubular bronchial breathing. Then when you can you hear me? Because it appears my network is a little unstable.
Very good.
Shall I put off the video?
No, we can hear you clearly, ma'am.
Yes.
Ma'am, what I'm going to do is I'm going to break in and play
Yes.
one audio video of vesicular breathing and bronchial breathing, and then we can get back
Yes.
to your explanation.
Yes.
Dr. Murali, sound is not coming through clearly.
Sound not coming. I am not sure how to make the sound come. Yeah. Hmm? Okay. Okay. Perfect. I'll do that. I'll do that. I'm not seeing any such button.
The computer sound is not being picked up. It's playing through the computer, this audio. No sound.
Recording, shall I try it? Play it?
Shall I finish off?
Madam, can I just play one? I have one recording. I just tried.
Of course.
Just see if it's making, you can hear. I just play it.
No, Dr. Murali has to stop sharing. Yeah. He has to unshare. Then only you can share, Dr. Screen.
No, I'm not sharing. I'll just play. It's an audio.
No, you can't do that.
Oh, I see. Sorry. It's okay. Then let it go. Shall I
share yours?
I can try it's just an audio. Is it audible?
Yes, but you can bring it to the mic nearer.
I think his audio is on the mobile, I think.
It's on the Bluetooth speaker, sir.
Okay.
I'm playing it through a speaker.
Ma'am, can you go ahead? I'll try and sort this technical glitch out and then we can restart.
Anyway, at least some ideas come. Madam, I think you can continue till that.
Yes. So when we were talking about the bronchial breath sounds, or bronchial breathing rather, and I explained about one classical situation where the conducting media is a solidified lung, which is a consolidated lung. Now let us look at completely opposite scenario where the alveoli are not solidified. Yes, wonderful.
I think we can get it now.
We are getting it.
You're getting it now?
Yes.
Fine, ma'am.
Play it again.
Let me go ahead with it then.
You can go back and play it again.
No.
The first part is more audible. You can go back and do it.
Yeah, so there I think they're trying to demonstrate that the inspiration is longer than expiration and that there's no pause between inspiration and expiration, as you explained, ma'am. Yes. Whereas I think when we go into, let me try and play the bronchial breath sounds for you.
Yeah.
So this is better.
Yeah.
I have one of vesicular. If you want, I can try that in case if it's okay. Or we can go ahead.
Okay, so as ma'am described, expiration longer than inspiration with a pause between inspiration and expiration is what was being demonstrated there. Sorry, ma'am, please go ahead.
No. Then I wanted to just explain on these basics only, like the conduction of the sound and the conducting media between the stethoscope and the patent airways. Then another situation is a little opposite. So, for example, there is upper lobe fibrosis, which is pulling the trachea towards that part. So, say it's a right upper lobe fibrosis, and the trachea or the airways are being pulled to the right side. And then when you auscultate, you will hear a bronchial breathing, but your diagnosis would not be consolidation. So why are you hearing bronchial breath sounds? That is because the sounds are, as I said, are being produced there from the larynx and passing through the airways. But even if the conducting media is not solidified, what has happened is the airways have come very close to the chest wall. And that is why when you place a stethoscope on the other side of the chest wall and the airways are almost near, those sounds are directly conducted and you will hear a bronchial breath sound at that particular time. So I think if these two things are understood, it's very easy. Once you identify bronchial breath sounds, it becomes easy what may have been the reason for that. Another reason is there for another condition, but I think I'll give space for others to speak about. Dr. Murali, do you want me to explain about bronchial other types just now, or shall we let Saket come in and we'll touch it later on?
We'll come back, ma'am, to let's let Dr. Saket go ahead with his, So, Dr. Saket, could you unmute yourself? And of course, welcome again to the chest, this conglomeration of extremely good, interested pulmonologists who will be very keen to hear a little more about cardiac auscultation. Dr. Nitin wants to add something.
Yeah. Just one clarification. I mean, we have, all these sounds recorded in the background. So if you say you want vesicular sound, just tell the technical team, they are able to play it. So, whenever you want it, just ask for it. You don't have to do it from your computer. We have it in the background.
Fine. Perfect. Okay. I think that simplifies things very, much. Thank you so much. Dr. Saket, few questions we had for you, but most importantly, you're dealing with pulmonologists here, and we are interested mostly in the right side of the heart, pulmonary hypertension, and so on. I'd like you to tell us a little about how to auscultate the cardia. What does one focus on, like we started with the respiratory system examination, and how are S1 and S2 relevant to the pulmonologist? Then we'll go on to some of the other findings in pulmonary hypertension. So over to you to tell us a little bit about cardiac auscultation.
Thank you, sir, for giving me the opportunity to interact with some of the greatest teacher of the pulmonology. And I feel really privileged to share the platform with such a knowledgeable person. So from the cardiac auscultation, actually one thing I would like to emphasize that we cannot hear everything. The limit of the human ear, what we hear is only from the 13 to 18,000 hertz. Most of the cardiac sounds, they are in the range of 30 to 1,000 hertz. Anything below 30 hertz or above the 18,000 hertz, we cannot hear. So we have to understand the limitations of the human ear. That's why we need more sophisticated technology, phonocardiogram, and other things. So, and one thing I would like, human ear cannot differentiate the two sounds which are closer than 30 milliseconds. The relevance of the splitting, we can hear split only if it is more than 60. Human ear can hear more than it is more than 60 milliseconds. That we will discuss. A2 P2 splits, which is important from the pulmonologist point of view. 30 to 60 we can appreciate or not, but more than 60 we can easily appreciate. So I would like to give details of the basic mechanism of the production of heart sounds. Then what is more important from the pulmonologist point of view, I will. So the mechanism of, I will like to talk about the mechanism of the basic heart sounds. What the conventional teaching is, we have 4 basic sounds, S1, S2, S3, and S4. So what we have conventionally taught is the valve closure give rise to S1 and aortic closure give rise to S2. But the reality is not that. The S1 is not produced due to the closure of valve. One famous theory, which is most acceptable, proposed by the Louis Sada. Actually, the production of S1 indicates the onset of ventricular contraction, and it happens after 50 to 60 milliseconds of the initiation of electrical systole. So what is producing S1 is the vibration of the septum, mitral valve apparatus, and LV valve. Similarly, the S2 is not due to the closure of aortic valve, but it is due to the sudden deceleration of the backflow of the blood from the aorta, which sets the whole cardiorespiratory system in the vibration. So that is the mechanism of the S2. From the pulmonologist point of view, the S2 has 2 components, A2 and P2. We have thought that there is a venous return in the inspiration, that is the reason for the splitting. But again, the more advanced theory, it is the concept of the hangout interval. So what happens during the inspiration, the lungs expand, which decreases the impedance of the pulmonary vasculature, which delays the P2. So that is the main reason of the A2 splitting of the second heart sounds. Normally, the importance of splitting comes when we are talking about the condition of the pulmonary artery hypertension. In the pulmonary artery hypertension, the impedance of the pulmonary vasculature, it increases, which causes the narrow split. So the different condition of the aortic and the pulmonary vasculature will decide the interplay of the complex mechanism will decide the A2 P2 interval. For the S3, again there are many theories. The most acceptable is the impact theory. What happens during the early diastolic filling? There is sudden deceleration of the blood. So, which against the put the cardiorespiratory system under the vibration, and that is the reason for the S3. Condition where the S3 gets augmented means S3 is loudest condition of the constrictive pericarditis. So, or any condition apart from the physiological reason, condition of the increased cardiac output, or otherwise it indicates LV dysfunction, or there can be the RV dysfunction, RVS3 or LVS3. For the fourth sound, S4, it is again the S3 and S4 are low frequency sounds. S4, presence of S4, it is a pre-systolic sound. The presence of S4 indicates the ventricular are stiff and atria are contracting against the resistance. One thing I would want to emphasize, for S3 and S4 to happen, there should be good functioning atria and there should be unobstructed LV valve. So, in the absence of if the patient has atrial fibrillation or something, aortic mitral stenosis or something pathology of the mitral valve, then it is unlikely that we will get the S3. So then come to second heart sounds. I would when we suspect there is pulmonary hypertension, what is severity of the pulmonary hypertension? So there is very much discussion about when we should P2 is loud. Sorry, there are many different experts in different view, but what the Professor Ramakrishnan from them, I think it is very easy to, in the second left intercostal space, the P2 is louder than A2. But it is very difficult to compare P2 with A2. Then what he says, if in the left second intercostal space, just you compare second heart sound with the first heart sound. If the second heart sound is as loud as S1, because normally at the left second intercostal space, S1 is loud. If we compare with S1, if the P2 is as loud as S1, then it is definitely loud. Or if P2 is palpable in left second intercostal space, then it is definitely loud and it indicates severe PAH. If P2 is auscultable at apex, it is definitely suggests severe PAH. If P2 is heard below the earth point or lower left atrial area, then it may suggest moderate to severe PAH. Then the next thing I would like to discuss the murmur of tricuspid dilatation. One thing very important, usually in the percent of good functioning RV, usually it is a pan-systolic murmur. If the murmur is early systolic or mid systolic, we must suspect the RV dysfunction, which is very important to pick up early. Another thing in the pulmonary click, ejection click is very much common, even in the Eisenmenger syndrome and early diastolic murmur of pulmonary regurgitation. So this thing is important from the pulmonologist point of view. And I would like to emphasize on the few cardiac diseases which you people more likely to get diagnosed, like the pulmonary AV fistula, peripheral pulmonary stenosis, coarctation of aorta, continuous murmur very frequently heard at the back, and condition where we have the large MEPCA. In all the conditions, we can have murmur at the back, and that will be the continuous variety. And one thing, actually in the pulmonology, we ask patient to open the mouth and take deep breath. But for the cardiovascular auscultation, we likely to keep the breath quiet or hold the breath, and all the sounds, cardiovascular system sounds are better auscultable when the patient hold the breath. So that is all I would. Any questions there?
Yeah, but we also like to ask the patient to breathe while you're looking for variability, and especially in the S2. Yes, so both with a breath held in inspiration, breath held in expiration, and with normal breathing. I think all three are important. We're going to play some videos again of the S1, S2, and then the fixed S3, and then the fixed and wide split of S2, which you can hear in ASD. That's something which we should not miss. It's an important cause of pulmonary hypertension also. And one of the commonest congenital cardiac anomalies, especially in the adult. There are a lot of adult pulmonologists. So our patients with pulmonary hypertension are often likely to have an unrecognized ASD, missed ASD. So we should not be missing this widely split and fixed S2 splits.
So one thing I would like to emphasize, the loud P2 in ASD does not indicate pulmonary hypertension. Even if it is there is no pulmonary hypertension, P2 is loud in the ASD.
It's largely because of the increased flow without having yet pulmonary hypertension. Yeah. So can I request our admin, Mr. Vinod, could you please play those few videos? So I think we're all aware of the normal S1 and S2. the lower pitched S1 and the more high pitched S2, the shorter gap with normal rates between S1 and S2, and the longer gap between S2 and S1. The next, he'll be playing the S3, I think. Vinod, S3, please. So I think this is fairly clear. You hear an S1 and S2 and a third sound there. If it's closer to the S2, we typically diagnose an S3. If it's at the apex, it's more likely to be an LV-S3. And if it's near the left heart border, it's more likely to be an RV-S3. Anything else you'd like to add to that, Dr. Saket? I've just given a very simple explanation.
Just to remember, I remember like the canter of the horse, it has been described, S3 described the canter of the horse.
I think it's called as gallop rhythm. Gallop rhythm.
Gallop, yes, sir.
And
Both S3 and S3. Yes, sir.
they're in the diastolic part.
Yeah.
Yes,
So if it is accompanied by tachycardia, then it becomes a gallop rhythm. So that's when you get the typical gallop cadence. Without that, it's just a triple rhythm or an S3.
Okay.
And you can get the same with an S4, but an S4 will be closer, as you said, to the latter part of diastole, closer to the S1.
Yes.
Can we have the widely split and then the transient split of S2, Mr. Vinod? Saket, can you take us through that, please? How does one differentiate between this and an S3? Because here also we are hearing three sounds. You can hear the distinct difference. I'd like Dr. Saket to explain the difference to us.
Interval between, sir, interval between.
Vinod, you can stop it. Mr. Vinod, you can stop this. Yeah.
S3 is more later, sir.
Yeah. So there's a larger gap between the A2 and the S3 than between the A2 and P2. And I think P2 is also more high pitched than the S3. So we need to look at both the pitch.
Area is important, sir. S3 is better auscultable at apex. So area is important.
Yes.
S3 is better auscultable at apex, and split is better auscultable at left second space.
So that's very important to remember. Very often we have another confusion with the opening snap, because the widely split S2, the opening snap, and the S3 occur all soon after the A2 occur. But in increasing intervals, the A2, P2 is the shortest interval of all. The P2 is higher pitched. The OS opening snap is less high pitched, but the S3 is a low pitched sound, as you said. And the S3. Yes, sir. Go ahead, please.
Yes, sir. OS is heard over the large area of pericardium, sir.
Yeah. And typically, as you move away from the apex, you'll start to hear the mid-diastolic murmur that accompanies it. Yes, and the murmur is a highly localized murmur. That's again a very important sign we should not miss. The murmur of mitral stenosis.
The S1 will also be prominent there, no?
Sorry, sir?
The S1 will also be louder.
Yes. So typically you get the loud S1, and that in fact is often the very first clue to a presence of a mitral stenosis, even before we pick up on the opening snap, and which is more difficult to pick up as it's buried in a murmur. And then you get the mid-diastolic murmur.
Regarding
The first
S2,
clue is often the S2.
Regarding S2, the variation of the respiration is very important. It's not difficult to pick up.
Absolutely, sir. So can you play us that transient split S2? You can hear now the S2 is not split. And now it's starting to split and get wider. And it again gets narrower.
Variation, this is showing
very clearly seen. So okay, that's fine. Mr. Vinod, I think we can stop there.
Yeah.
And the last thing, I think we have a mitral stenosis. Can you play that? And I'd request Dr. Saket to take us through that thing also, the mitral stenotic murmur, because these are very important. You cannot miss a mitral stenosis as a cause of pulmonary hypertension. You cannot miss an ASD as a cause of pulmonary hypertension. And the earlier you pick it up, before irreversible changes occur, before the pulmonary pressures reach systemic levels, it's very important that you can intervene and do something for these people. Here you're clearly hearing the loud S1, followed by an S2. There's an opening snap and a faint mid-diastolic murmur. So I think here the clue, as Professor Chhabra said, is very importantly the loud S1, which you're not hearing with the other conditions.
This one is also showing pre-systolic accentuation.
Accentuation. Absolutely, sir. Yeah. So sometimes when the heart rates are fast, these things are difficult to pick up. So that's why the importance of having a diagnosis earlier, having a high index of suspicion. The minute you hear the loud S1, you start thinking, is this only due to tachycardia or is it a part of mitral stenosis? And then you look very, very carefully, auscultate at the apex, move away from the apex, put the patient in the left lateral position. Dr. Saket already told us, auscultate an expiration and see now if you can hear the mid-diastolic murmur of mitral stenosis using the bell of the stethoscope. This is one of the few conditions. Professor Chhabra said we usually use the diaphragm for all respiratory examination, whereas for cardiovascular examination, very important to use both the bell and the diaphragm. Dr. Saket, anything else you'd like to add?
I would like to add the very important look, the apex will be not separated. In mitral stenosis patient, apex will be at its usual, unless it is associated with some recurrent lesion. And the prominent parasternal pulsations that will indicate the severity of the pulmonary hypertension. And one thing more, sir, S1 will be palpable, sir. The one time if you palpate the S1, that will you will remember for the typing.
Absolutely. So that is one of the most useful things. So that is the importance of palpation, locating the apex, feeling the apex beat, and also looking for a palpable P2 when you're looking for pulmonary hypertension. But this time we decided to concentrate only on auscultation because there's so much to do. So thank you very much, Dr. Saket. Anybody else would like to add anything? Then we'll go back to Professor Munje, Radha Munje, and ask if she wants to add anything else about, or we'll come to Dr. Nitin. No, I think we come to Dr. Tridib. Dr. Tridib Chatterji, can I request you to tell us a little about these added sounds? What exactly are these added or adventitious sounds? How do we recognize them? And I think you'll be playing us some of those audios at the same time. So please tell us a little about what these adventitious sounds are.
So thank you, sir, for this question. Now the adventitious sounds which are added onto the normal breathing. The normal breath sounds which Sir Chhabra sir described and Madam was also describing. So bronchovascular or bronchial breathing. Along with that, there are some additional sounds which are produced inside the airways. So these are 3 or 4 main: the crackles, or you can call them rals, wheezes or ronchi, stridor, squawks, and rubs. These are the 4 or 5 major ones. So I'll start off with crackles first. So the crackles are, these sounds are basically divided into continuous and discontinuous. The continuous ones are typically the stridor and the ronchi. So they generally are more than 100, 200 milliseconds. So, and the discontinuous ones are the interrupted sounds, and they generally last maximum 10 to 20 milliseconds. The classical example of that is the crackles. So crackles are again of majorly 2 types. Some people also call fine, medium, and coarse. But broadly we call them as fine and coarse. Now there are many theories to this generation of the crackles. So one of the theories is that when the air goes through some secretions which can occur, say in a lung abscess or a bronchial cavity, But that's not the only theory, because when the patient coughs out and still, or an ILD will still get a cough. So that's not the only theory. The other theory is that there's certain opening up of the airways, which are at the end of expiration, they're when the air is gushing in, they suddenly open up, and there in that opening process, it produces that sound, and that produces the crackle. Then some more people have also got some liquid where it is not actually the air, but the vibration which it occurs during that time. Some people have attributed that to the cause of the crackles. So various theories are there. So anyway, this is all a theoretical thing. The main thing is, so far as we are concerned, is fine crackles and what time? The inspiratory, early inspiratory, late inspiratory, or it is expiratory, or it's continuously all the time. So the fine crackles, let me start with fine crackles first. These are the sort of explosive sounds which are very fine, and they generally are the ones which will not get influenced by coughing or but it can get influenced by postural change, but not by coughing. Unlike coarse growls, which might get altered by coughing. So that is that, and I'll just play one example of a fine crackle. It's on a Bluetooth, so I hope it will play well. Just bear with me. Now, this, if you can see, this is typically inspiratory. You are hearing it in the inspiratory phase.
Yeah.
So that's it. So it's again getting repeated. So that is the inspiratory crackles. Now, these are commonly seen in various conditions, of which one of them, it's in early pneumonia, you will see it. In early left ventricular failure, you will see it. And very typically, as sir had already referred to, one variant of it, which is just like when you open the Velcro or BP instrument, there the Velcro rods, which is very diagnostic, not pathognomic, because also seen in some other condition. But well, if you pick it up early, then you should actually, in an elderly person, start looking for it. So Velcro rods, which is another cause of these fine rods. Then, as against this, there's this coarse rods, which are much more harsher in this thing, hearing. And these things change with, they will not be influenced by position, but coughing, etc., the rods may become less. And this is typically seen in lung abscess, sometimes in COPDs, sometimes in bronchiectasis, where you will get these coarse rods. I'll just play one example of that. And here it is usually seen in both the inspiratory and expiratory phase. So inspiratory phase and expiratory phase. Unlike the other one, which is mainly usually in the inspiratory. So this is about the RALs. Shall I talk of bronchi just now, or shall we do it later on?
Why don't we come back to it later, and we'll request Dr. Nitin Abhyankar to tell us a little about voice sounds.
Yeah, okay, I'll stop.
Yeah. So normally when you're examining auscultating, I'd like my postgraduates to talk about breath sounds, added sounds, and voice sounds. And very often they leave out voice sounds because it's something active. Yes, Professor Chhabra, please go ahead.
One minor comment. There's a lot of confusion about terminology, both among examiners and among literature articles also. Crackles, crepitations, rals, these are all discontinuous sounds. And the standard book of Forgax that says that only use the term crackles. And that represents both crepitations and as well as rals. So to have a uniformity and to prevent confusion, that is a recommended terminology.
I completely agree with you, sir. Even in whatever literature I read, this Forgax is mentioned this thing. Completely correct. Same thing, sir, with wheeze and ronca also. Some people do not agree. They just call it high pitch wheeze and low pitch wheeze. And they don't use the term ronca at all. So this confusion is always there.
I think we should just stick to wheezes and crackles. I think people understand that well. And it seems completely unnecessary to use additional terms. And another good reason for not using growls is it originates from a French word meaning death rattle, which is not something very nice to use when you're describing a patient. So, Mr. Vinod, we'll come to this later. Let's not play it now. Or shall we play it again? And then I think I'd like to play that at the end. Nitinji, can you go ahead and tell us a little about voice sounds, how they are generated, and how one uses them for diagnosis?
Very frankly, I'm not the expert of, say, whispering, pectoraloquy or egophony or things like that. I mean, very frankly, last 3 years, I have been hardly using the stethoscope. Last decade, it has been declining. Last 2 decades, it has been going down and down and down. So I think I did all that as a part of my training part. But if you really ask me today, am I really using these to diagnose, say, pleural effusion and the interface between the pleural effusion and normal? I am not really very frankly doing it. So if you really ask me, this is, getting into, for that matter, when we are trying to demonstrate S1, S2, S3, I think things get very complicated when you are trying to really listen to them. And then, trying to really get egophony or, any of those voice sounds. I think it's extremely difficult. B, it's extremely labor intensive. Sorry to say that word again and again, because labor intensive seems to be a cliche that I use it. But I mean, we have so much fantastic tools. I mean, just put in a USG probe and you have it. I mean, today we just did a thoracoscopy, and just before thoracoscopy, we were not clear where is the diaphragm, what is happening. So all we had to do is, obviously, just put a, USG probe, and we had that sorted out. So I didn't resort to egophony while I put in a trocar there. So as simple as that. So I think I'm not saying underestimating the value of those. I'm saying yes, in a resource limited situation where you don't have those things at your disposal, please do use them. Please do use them religiously. But at the same time, we cannot sort of try and keep doing it forever and ever in a tertiary care setting where everything is at your disposal and you are in a situation where you have to take the next step. And that next step is going to be possibly putting in a trocar in a thoracoscopy and take a biopsy. So, well, I mean, that was over in 20 minutes today. But then, so all said and done, if I'm trying to make a diagnosis in a very difficult situation, in a very remote kind of a situation, yes, the voice sounds will make sense. But otherwise,
I'm going to argue with you and then hand over for additional support to Dr. Chhabra. But
yes, I don't mind a counter argument to this, please.
It's quicker for me to do a vocal fremitus and resonance followed by, as part of the examination than to go in search of an ultrasound probe, put the patient in the right position, put the jelly on the patient, put the probe on the patient. And before this, I should have got permission to use an ultrasound given the current PNDT regulations and so on. So to me, that is far more labor intensive. Different when you're doing it. I agree with you. When you're doing a thoracoscopy or doing a pleuroscopy, you must do an ultrasound. There's no question about it. But I think sitting in the OPD...
It's almost mandatory there. It's almost mandatory.
It's mandatory, absolutely. But sitting in the OPD, should I take this patient down and put an ultrasound probe on him? I would like to do this examination. Sir, I'll hand over to you, Professor Chhabra.
See, these additional signs, with WP, bronchophony or increased vocal resonance, and egophony, these are basically confirmatory signs for bronchial breathing. Just to confirm, so WP is just bronchial breathing that you get when the patient is whispering. When patient says 999, that's vocal resonance. So, and I entirely agree with Dr. Nitin that somehow these tests, they have lost their utility. By all means, if resources are there, so it depends on your skill as well as time at your disposal. In a long case, certainly students are expected to do, because that's a skill that should not be lost, even if it has a historical perspective and relevance. No, but these are confirmatory tests for consolidation.
Yes. Yes. And can I add to that, Dr. Chhabra?
Yeah, please.
Yes, ma'am.
I always say that if a student cannot make out a bronchial breathing, yeah, or if the patch of consolidation is small and he really cannot reach that particular area, the best thing for him is to look for all these vocal sounds of WP, vocal resonance, and all, and because these sounds are being produced and are better conducted and better appreciated. तो मैं तो ये बोलती हूँ कि आप ये करो, confirm करो, then go back and listen to those sounds and then say confidently, this is bronchial breathing.
I have one video on bronchophone in case for students, if you want, I can play it.
Sure. But I just want to make one comment. This patient I spoke about earlier with the multiple problems, we've been seeing him from 3 days. He had classic signs of consolidation day before yesterday. Today, they've come down. The vocal resonance is definitely less. The whispering pectoraloquy has disappeared. I don't need to do anything more along with his clinical improvement to say he's getting better. Now, day after tomorrow, I find the vocal resonance has come down on that side as compared to the other side. I'll know he's developing an effusion. I'll take him and do an ultrasound. So I think that's the relevance still of doing this clinical examination. Doesn't take more than a couple of minutes to do these things.
Exactly.
Yes, can I add something to this?
Yes, ma'am, please.
Yes. What Dr. Murali has described, I usually ask my students, and I sometimes, if I get time, जो हम पहले बोलते थे कि आप चेस्ट एक्सरे का डायग्राम बना के उसमें लिखिए क्या है, so the same thing I tell about the sounds also, like you mark the areas where there were crepitations or the breath sounds absent or something which has come new. So just looking at the picture, earlier one and the fresh one, you can really make out what is happening inside.
Dr. Tridib, you'll go ahead.
Just one of the objective examination is to draw a diagram which should look what you expect from an X-ray.
Exactly, sir. Yeah.
I have just,
ma'am said, I've worked at it both ways. When I was in the UK, we used to get one big pile of X-rays. So what you do sometimes is you examine the patient, then look at the X-rays. Sometimes you look at the X-rays and then go back and look at do the examination. That way you develop both skills, the X-ray reading skill as well as the clinical skill.
Just like you have good clinical practice, you have good examination practices, and these are part of good examination practices.
Absolutely. Agreed.
Dr. Tridib, you can go ahead with that bronchophony.
I have one of bronchophony only. I just played.
While we're searching, I just want to emphasize that bronchial,
which is the Greek word for the voice of a goat, refers to the nasal or bleating quality of speech transmitted through consolidated lung tissue, as in pneumonia.
He becomes a.
Occasionally, egophony will be heard over a pleural effusion when there is collapse of the underlying lung. When egophony occurs, if the patient says E, the letter will sound like A, because there is transmission of the higher frequencies or formants. First, you will hear the letter E spoken over the healthy side.
Normal sound. Now
you will hear the letter E spoken over the area of consolidation.
So that's it. That is what he said.
Yeah, and as he said, its agophony comes from that goat bleating sound. I've heard postgraduates teaching that it becomes, E becomes A. That is why it is called egophony, which is not right. Okay, it sounds like it. Yes, that E sounds like it becomes A, but that is the goat bleat and is not the way the word was discovered.
And sir,
described.
In fact, I feel we should go back to the vernacular, or the goat में करती है. If you remember that में या मेमने ने कहा, तो वो sound बराबर correlate होगा rather than talking about egophony.
But sir, I mean,
absolutely.
At least during my undergraduate days, this whispering petrology, I mean, it's really nice to hear. Hey, somebody says,
Yes.
and you, as if you hear it in your ear. I mean, everybody should hear it once. I mean, all students should definitely. I mean, I understand Nitin's point, but I think we should all hear.
You know, this reminds us all of us.
Basically, it's important not only to learn about these sounds, hear them, interpret them, but most important is correlate not only with pathology, but understand कि ये pathology की pathophysiology क्या है. Why and how the sounds are being conducted so that you can hear it in a exaggerated way. वो तो exaggerated आपको सुनाई दे रहा है ना when you're talking about bronchial breathing.
Yeah.
So वो समझना I think is more important.
No, it is different. Go ahead.
For example, you said, ma'am, consolidation. You know, so it tells us that the lung is solid. That's literally what consolidation means. And that solids conduct sounds well to the surface. And these are faithfully conducted, both high and low pitch, which is why bronchial breathing is relatively high pitch conduction.
And in that, the bronchi are patent. I mean, the bronchi are patent, which will reflect as an air bronchocommon on X-ray. So you kind of
perfect. Correlate them all. Whereas in an area of collapse, you will not get it even though it has become solid. You know, so those are the important messages that you learn when you're doing this examination and you understand the underlying pathology. One of the exceptions to this collapse being associated with bronchial breathing, or where collapse is associated with bronchial breathing, is the rare condition where you have a right apical collapse and the collapsed segment of lung is abutting the trachea, and the sounds are conducted directly from the trachea to the chest wall. So that's one of the few exceptions when collapse is associated with bronchial breathing. Normally it is associated with diminished intensity of breath sounds. Yes, ma'am. Let's take some of these questions from the audience. I'll start with the one that's already on the thing. I copied a few earlier. The question from Dr. Ruby Joseph from my own city of Bangalore. Dr. Ruby asks, in case of a peripheral consolidation, does one not hear bronchial breath sounds because it is peripheral? The airflow is already laminar and not turbulent, though the alveoli have solid exudates. Ma'am, could you take that question, please?
Yes. Whenever there is consolidation, just because it is peripheral, you would not hear bronchial breath sound is not true. However, the intensity of the sounds may be a little less for you to appreciate it as a bronchial breathing. And that is why the things which we discuss is confirming it by WP and all becomes more important and relevant. Yes, Chhabra sir.
See, one thing is very important. The consolidated area must be abutting the chest wall.
Yes, near peripheral hai to nahi aayega aisa nahi. Probably what she means to say that if the consolidation is peripheral, the airways have already divided, and how can it be bronchial?
The small consolidation.
So it is not with the airways. So we have to tell Ruby that it has nothing to do with the branching of the airways, but it is to do with the patency of the airways and the solidified transmitting media or a conducting media in between the chest wall and the airways.
The other thing I'm telling you is sensitivity. When there are small consolidations, patchy consolidations, then also don't get bronchial breath sounds because...
No, you won't get. उनका बोलना peripheral है, patchy नहीं बोला ना.
Peripherally large.
Patchy so we are likely to miss because you will get only crepitations at few places.
Peripheral large sitting on a bronchus, you should get a bronchial.
Yes.
Yeah, but I think we have to understand that everything has limitations. So I think we can't expect, unless until it's a large lobar consolidation, you are not going to get the classical sounds that we are looking for. So I think if it's a patchy, small or a small peripheral infarct like consolidation, or a boop which is peripheral, you are not going to get the classical sound. So I think we can't expect the sky from only auscultation. That is not going to work. So I think we have to match and marry multiple skills and get to the diagnosis. Basically.
Absolutely.
Still, that's the point. Abnormal signs there.
Pardon, sir?
We'll still have some abnormal signs, like a few.
Oh yeah, absolutely.
You may not make complete sense of them, but there are some abnormal signs. Absolutely, absolutely.
And the point I also want to make is that these signs don't rule out absence of these signs doesn't rule out the condition.
Yes.
Their presence increases the likelihood of the condition. That's very, very important to remember.
Correct.
Don't say, I cannot hear bronchial breathing, so this is definitely not consolidation. When you have all the other history, physical signs, as you know, sir said, crackles are being heard there, and you're seeing a patch on the X-ray and saying adamantly, no bronchial breathing, so this is not consolidation. That doesn't apply. Right. I think there was one more question. Just let me get to it. This was about, can you hear bronchial breath sounds in severe empyema case without consolidation? I think that probably was emphysema, though it was written as empyema. But let's take both. Professor Chhabra, Professor Munje, can you tell us, can you hear bronchial breath sounds if there is severe emphysema?
No.
Even when there is no consolidation?
No, you cannot, because the alveoli does not act as a conducting media, and in fact the alveoli have ruptured. So either in case of empyema or even emphysema, you will not hear bronchial breathing. What happens in empyema is that the conducting media of that fluid stops at the visceral pleura, and from visceral pleura to the parietal pleura, the fluid is there, and thus the sounds which are reaching to the visceral pleura are not coming to the chest wall, and hence there would be rather absence of breath sounds than bronchial breathing.
Emphysema is something which has a very high specificity on examination. One can pick up emphysema and it gives you a distant, reduced intensity of breath sounds.
Yes.
Very faint breath sounds. And coupled with the barrel-shaped chest, you're almost certain that it's emphysema.
The important thing to remember is it will be vesicular breathing, but the expiration may be prolonged.
Yeah.
Okay, and that doesn't make it bronchial breathing.
Yes.
The important features are the quality of the sound are not bronchial. There is no gap between inspiration and expiration. Just the prolonged expiration doesn't make it bronchial. There's another question from Dr. Madhav Kale. He says amphoric breathing is pathognomonic of IRGE. What is that? I'm sorry.
Large
P Dumo.
I think you
large, probably yes, we missed on this explanation, Dr. Murali. So I would take the opportunity to explain.
Yes. Good
when
time
we were
to
talking about bronchial breathing, we did not comment upon amphoric breath sounds. So what are these amphoric breath sounds? These are also high-pitched bronchial breathing, but with a metallic tone to that sound. I always say that now that you use plastic bottles, these sounds are not so well heard. But it's worth experimenting with a glass bottle, which earlier we used to call, I don't want to advertise, but Coca-Cola या Fanta की जो bottle होती है, उसका the opening is small. What we have to understand is the opening is small. So when the air gushes through a small opening in a small tube, it would cause more turbulence and metallic sounds are created. And these are the amphoric breath sounds. Classically heard with, a cavity with a smaller opening, we would say, or even if it is pneumothorax with a small opening and you can hear an amphoric breath sounds. The other type of bronchial breathing, which, yes, sir?
High-pitched sounds.
High-pitched sounds, yes. And the only sounds which has been left behind from this category is cavernous bronchial breathing, where you need to have either a large cavity with a smooth wall or a large or a pneumothorax, wherein the opening is very wide. So because the turbulence is not being created, the metallic sound is lost. And you hear this bronchial breathing, but this is not a high pitch, but a low-pitched bronchial breathing, which you hear.
It's a bit hollow. Hollow.
Yes, hollow.
This described as hollow.
Basically, these are bronchial, so they have to be hollow. Yeah. But the pitch,
pitch is on the lower side. And the metallic sound is not there.
I might just clarify that the person who has asked this question, Dr. Madhav Kale, is the senior most teacher in Pune in KEM hospital, and one of my, I'm a favorite student of him, if you want to call it, or other. He is my favorite teacher, and he is the one who was cleared an Hermes exam at the age of 72. something like that.
Wow. Wow.
So we are honored that he asked a question and gave us an opportunity to go back to the
every single webinar CCI does. So.
That's very, very encouraging and heartening, you know.
You should call him for one of the
Sincere
webinars then. I think.
Our sincere thanks.
Yes.
Absolutely, absolutely. We are honored, sir, to have a question from you and to, actually have you attend all these webinars. I think it just is, you're so inspiring. That's all I'll say. So I think we have one more question. I think really we've answered this, but I think I'll ask Professor Chatterji and all the others to tell us, do you still use the terms rhonchi and wheezing separately, or are they the same?
I think we talked on this, sir. I mean, this is, I think it's just a question of pitch, high pitch wheeze and low pitch wheeze. So I think, as sir said, and you also said, it's better to stick to high pitch, low pitch wheeze and then take out this word rhonchi.
Wheeze is something which, wheeze is a symptom, rhonchi is a sign.
Yeah.
Wheeze is what the patient comes and tells us.
And sometimes you auscultate over the chest and you call that rhonchi you have heard. But basically you are kind of describing the same thing.
I think rhonchi is firmly entrenched in our terminology.
Yeah, it's an old thing.
So in fact, what you can hear with the unaided steth and the patient hears is called an audible wheeze. And if it's not, we are using the steth, we just call it a wheeze, not necessarily an audible wheeze. So, these are just terminologies, but that's the question which actually Dr. Suresh Kumar from Andhra, Kadapa has asked. What is the latest classification of lung sounds nomenclature? So again, there's a lot of confusion. I'm going to, say something and then request the other panelists to come in. You have the ATS nomenclature, you have the British nomenclature, and you have the general nomenclature. And there's, by and large, good concordance between these. I would suggest you stick to what Paul Forgak said. I think he's got the best description, the best understanding of the physics of lung sounds. So I would stick to that. I think we should just call them crackles, wheezes, and I don't think we need to go beyond that. And bronchial breathing is high-pitched, medium, and low-pitched. If you want, you can call them tubular, cavernous, and amphotic when it has the metallic overtones. And of course, you have the basic classification of continuous and interrupted sounds. And interrupted sounds includes pleural rub. Does anybody want to add anything about the pleural rub before we go to the last question and then stop?
I'll say since I have a audio on that, I think I'll just speak on that. So this pleural rub is generally what is seen in the early stages of pleurisy. Typically, it does appear like crackles, but the differentiating point is that it is generally localized over one area. It's at the basis mid-axillary line, and typically, when you press on with your stethoscope, it gets accentuated, and the patient generally tends to get little more pain. So, and sometimes it is also pericardial rub also comes in, and again you can get confused with that. So that's one way of differentiating is you just ask the patient to stop breathing for a second. And if the rub continues, then you know that's a pericardial rub and not a pleural rub.
See, the frequency is important. The pericardial rub has a cardiac frequency. The pleural rub has a respiratory frequency.
No, the problem I think is when you have a pleuropericardial rub, then it gets more confusing. And that's when holding the breath is very, very useful.
So if you want, I'll play one quick video of audio of a pleural rub, since we are on that line. Is it okay?
Sure, sir. Yeah, please. But in the meantime, there's one more question from Dr. Ramakrishna Paramhamsa from Rajamundry. Tell me when you're ready, sir.
I'm ready. If you are.
Please go ahead. Please go ahead. Then we ask the last question.
Okay.
Pleural rub. Normally, the pleural surfaces move smoothly and noiselessly against each other.
Sorry.
Pleural rub. Normally, the pleural surfaces move smoothly and noiselessly against each other during respiration. But when the pleura is inflamed, as in acute dry pleurisy, before any inflammatory fluid collects as effusion, the two inflamed and rotten surfaces of the pleura rub against each other and produce a creaking, grating sound termed as pleural rub or friction rub. is commonly.
That's it.
Okay. Right, sir. So last question, and then we close. To answer, Professor Radha Munje was asking how many logins. There are 1113 logins, over 1,000 logins.
Wow,
so
that's great.
So clinical medicine is still not dead. There's still interest in clinical examination.
In fact, sir,
Yes.
I when I spoke in my hospital, many of my surgeon friends said, hey, we want to attend and do refresher course. But they haven't seen a stethoscope, much less holding it for many years.
So last question from Dr. Ramakrishna Paramhamsa Rajamundry. He says, is not the underlying atelectasis cause for diminished breath sounds and pleural effusion? Because fluid is a better conductor of sound. It's not the medium that causes diminished breath sounds. Again, open to all of you.
Can I answer that? I think because it's what he's saying is wrong. The sound waves travel faster in solids than liquids, and they travel faster in liquids than in gases.
Correct. So I think he's emphasizing that it's already reached the liquid, it should get transferred better. So why is the breath sounds diminished in intensity?
So fluid will always filtrate out completely.
Absolutely.
So the usual explanation I've read is that the lung is partially collapsed, and you have the sound waves having to pass through multiple media. At each interface, there is a loss of sound energy.
Yes.
And that's why by the time it reaches the surface, there's a significant loss of sound energy, diminished intensity of breath sounds. And when I teach my students...
Sir, इसके लिए मैं एक example देती हूँ कि when we always say कि दीवारों के भी कान होते हैं. So the best thing is like if you are knocking or making a hard sounds on a wall and you keep your ear on the other side, you are able to hear. But if you are knocking one wall and keeping your ears to the distant wall, बीच में खोली है, room है, which is filled with air, you will not hear the sound. They can try this experiment and see.
Yeah.
I also tell people it's this, like children use this telephone with two pins and a thread in between.
Right.
Stretch it out.
Right.
That's when you hear the sound best. If you allow the thread to relax, then you don't hear the sounds at all. And that is similarly to the partially relaxed lung that doesn't transmit the sounds well.
And one important point is that when there are multiple pathologies, you do get differences away from the classical pictures that we talk about, or the quantity of fluid. So all that is
even if you have a classical consolidation, a lobar one, but once you have effusion, the sounds will be dampened.
Yes.
You won't even hear a bronchial breathing at that time.
Absolutely.
And at the same time, if you have a massive pleural effusion completely occupying that lung, you'll actually hear bronchial breathing because the sounds are conducted directly from the patent bronchus to the chest wall through fluid, which is an excellent conductor of sound.
This is exactly what I was going to tell you. Good. Great.
I think the more
important thing that I'd like to emphasize when you are talking about bronchial breathing is don't focus only on the intensity of the sound. Focus on the pitch of the sound. Focus on the gap between inspiration and expiration. Students very often try to only look at the loudness of the sound. And in fact, with a massive pleural effusion, the sound is often diminished in intensity, but has a peculiar clarity, which is important when it comes to bronchial breathing.
See, pitch and amplitude are entirely different attributes of sound.
Absolutely. Absolutely. That's something we all should remember. And, I usually tell people when you think of pitch and frequency, as ma'am was emphasizing earlier, high-pitched is like Lata Mangeshkar and low-pitched is like Amitabh Bachchan, very different. So don't look at how loudly they are singing or talking. It's the quality of the sound, the frequency of the sound waves. Right. As a last encouraging thing to all of us, Dr. Kaushik Mandal says, please repeat the webinar. I think that is in Dr. Krishna's hands. I'm going to stop at this point.
It's repeated it's on YouTube after 1 week.
Forever.
After 1 week, it's put up on YouTube.
Absolutely. Just listen to it and let's focus on newer topics when we do more webinars. I'll thank all our panelists and my good friend and hope we meet multiple times on platforms like this. thank our admin and tech support team. Mr. Vinod has been wonderful. They put together these audios, videos, and I think those have been extremely helpful. We'll play them once again for audience to listen to them again. And at the end of it, we'll wish you all good night.
Thank you.
Yes.
Vinodji, please go ahead.
Thank you.
The efforts of CCI in making a library of these lung sounds. So we must.
And a very special thanks to Krishna. Dr. Krishna insisted that we should have this topic. And I think he knows the pulse of the audience, what is really needed. He was keen that we go into the basics. So thanks, Dr. Krishna, Dr. Vijay, Dr. Atri, for all the support you all have given us.
Thank you all.
Thank you. Thank you, everybody.
Thank you, Team CCI. Thank you.
Honored to be here.
Yes.
So that's an ejection systolic murmur. You can hear the S1 and the S2 fairly clearly, and it's got an crescendo decrescendo quality, sometimes described as a diamond-shaped murmur. Dr. Saket, anytime you feel like coming in on any of the cardiac things, please do, and the other panelists for all the respiratory things. Not that the other panelists shouldn't come in on the cardiac things. All of you are physicians.
In fact, it would be good to hear Dr. Saket's comment on these heart sounds, you know. It would be revision for us.
So we've discussed this earlier, ejection systolic murmur and a persistently split S2. It remains in both inspiration and expiration. And as Dr. Saket mentioned earlier, it does not mean to tell you anything about pulmonary hypertension in this case, neither the murmur nor the loudness of the S2. Dr. Saket, why is this called a holosystolic murmur? Can you explain to the audience, please?
Holosystolic, it starts after S1 and it persists throughout the period of systolic. So,
and typically occurs when you have a murmur at the AV valves.
Yes, sir.
Is it same as pansystolic or is different? Like a mitral regurgitation, you get a pansystolic murmur. Is this different from that?
I think terminology is same, sir. Holosystolic and pansystolic are the same. I have not read anything like that, but I think both are the same.
Absolutely. I think we should call them the same. Some people like to emphasize that the pansystic murmur spills over S2 and a holosystolic murmur does not. I don't think that really is validated in any of the studies that you showed us, sir. Next video, please. Yeah, this is often the most confusing. When will we say a murmur is innocent or physiologic, Dr. Saket?
So especially when it is associated with certain tachycardia, like smaller children, neonates especially.
And you see no reason to suspect cardiac and other physiologic causes like anemia and so on.
Anemia, hyperthyroidism.
Yes.
Neonates.
Output states. Yeah. Yes. Perfect. Thank you. Next video. Yeah, take us through that, Dr. Saket. One of the most common cardiac conditions.
Yes, sir. One thing I would like to emphasize in mitral valve, it is a murmur is to late systolic, sir. Unlike the murmur of mitral regurgitation, it starts in the early part of the systole. The murmur of the mitral valve prolapse is mid to late systolic. And
so it's a non-ejection click, mid-systolic click, and followed by a late systolic murmur.
Yes.
And we won't go into the physiologic maneuvers. Those are too confusing for this time. But there are maneuvers that you can do. A much better way is obviously to do an echo to confirm your diagnosis.
Anything that reduces the pre-load start will augment the murmur of mitral valve prolapse.
Mitral valve prolapse. Thank you. Next video, please. I think this we've discussed the normal S1 and S2, nothing specific, but useful to remember this to contrast it with the videos, audios that are coming. Next audio, Mr. Vinod. So this, they've largely taken out the murmur that you heard earlier when you were hearing the ASD, and here you're seeing the persistently split S2 very well. And contrast that with the transiently split or mobile split of the S2. Next video, please. Dr. Saket, this S3, can you describe again, please? You did it earlier already.
Yes, sir. Just remember the tender of the horse, what we described.
Yeah, so this is the split S1. The important thing to realize is this is the S1. And I always teach my students, when you're auscultating the heart, your other finger must be on the carotid to first identify which is systole and which is diastole. If you don't do that, it's very easy to confuse your goalposts and wonder which is S1, which is S2. Look at the characteristics also, but please start with your finger on the carotid and identify systole, diastole, S1, S2. Once you establish your goalposts, focus on each sound independently, then focus on the gap between S1 and S2, that is the systole, then focus on the gap between S2 and S1 diastole. First look for added sounds, then look for the murmurs. It's very confusing when you hear a whole medley of sounds. So in your mind, you have to focus on one part of the cardiac cycle at a time before you can, before you try and identify which is the sounds, which are the murmurs, what is the timing, and so on. So it's very important that you break it down bit by bit.
And sir, may I add on this? When you're seeing the murmurs, you can see when it's radiating, like an aortic stenosis murmur will tend to go up over the carotids, and you will start hearing it more. But a mitral regurg, that hollow cystic or pen, tend to go down the axilla. I mean, it will just, once you've identified, it may help you in guiding further.
Absolutely. So we teach about 10 different things to be described in a murmur, 8 compulsorily, and an additional 2 physiologic and pathologic maneuvers only in some cases. But the other 8, I think, are very critical. And one of them, as importantly, as you said, Dr. Tridib, is the radiation of the murmur, where it is radiating to. Next one, please. Yeah, this is the transiently split S2. Present, disappeared, present again. Reappeared, now disappeared. Next slide, please. Next audio. Dr. Tridib, you can talk us through this, please.
Dr. Murali, excuse me, may I please leave?
Yes, sir. Thank you so much.
Thank you. It was a pleasure being with you all.
And as usual, you make a great contribution. Thank you so much, Professor Chhabra.
You are on a mute, Dr.
These are the coarse crackles which you are hearing in both phases of the expiration and inspiration. Whereas the earlier one, if you had noticed, they was the only during the inspiration, they were the fine crackles. This is the one which can change with coughing and not with position, where the other one will not change with change with position and not with coughing.
Right, next one, please. Okay, this is a little difficult to make out. You should have the normal breath sounds before you can tell this is.
So here it is.
But otherwise, yeah.
Because we are hearing it amplified with
amplified. So you just hearing actually more the almost like a bronchial.
Exactly. But here you can make out that there is no gap between inspiration and expiration, does not have that hollow quality.
Yes.
Just the intensity is supposedly reduced.
That is a very important point. When you're bronchial, you should look for that gap, because there's no alveoli involved. So the gap is an important distinguishing point.
Right? Anything more, or is that the last one, Mr. Vinod? Respiratory.
And here, these are called as a polyphonic wheeze. That is, the wheezes are of different musical tone because different parts of the bronchi are vibrating together. As against that, there is a monophasic wheeze, which is seen in a tumor or something. I don't know whether it will be there in that, which is generally seen during inspiration only, whether the tumor or a foreign body, which is very important. That's a very important. People are treated as asthma when it's just a foreign body, localized at one side.
So fixed, localized, monophonic wheeze.
Fixed monophonic. This is the rub, which we had. Always differentiate it with what it can increase on pressure, and it is over the generally the mid axillary lines. As diffusion develops more, the rub will go away.
And this is typically biphasic or monophasic, whereas the pericardial rub is a triphasic rub.
But sir, in pericardial rub also there is many times a monophasic also.
Yes, absolutely.
These are the sounds which are best heard in inspiration, and everyone heard over the trachea. You don't even need a stethoscope, you can hear it by itself. And this is, when there is strident, it's generally an emergency and you have to do something about it.
And wrongly being treated for uncontrolled asthma many times.
That is one important thing that is called as vocal cord dysfunction, which is many times missed with this. And as Madam said, I saw the literature, there is some 40% of people have gone to multiple times treated as asthma when they have got a vocal cord dysfunction, where then you diagnose by doing laryngoscopy, etc.
And you can have a similar kind of appearance when you have a retrosternal goiter, which again has often been mistreated as asthma for many years.
So there is spirometry where you see each. So here you can typically see there is no gap. It's inspiration, which is much more, and the expiration is shorter here. It's 2:1, 3:1, and 2:1. So inspiration is longer, the expiration is shorter.
And here you cannot make out the pitch, but as Madam was telling us, this tends to be lower pitched. Bronchial breathing tends to be higher pitched. Okay. Right.
There's also something called bronchovesicular, which is supposed to have.
I wanted to add something before we end.
Yes, ma'am. Please do.
Since the webinar is on heart and lung sounds, I think we have missed on the area of your interest, which is pulmonary hypertension. And I feel no pulmonologist should miss a loud P2 clinically.
Absolutely. So focus on the P2. I think Dr. Saket actually told us, how to identify when the P2 is loud, the S2 is loud, where you listen for it. Very, very important. And, it's something that as pulmonologists, we should never miss. However, in a patient with COPD, remember that absence of a loud P2 does not rule out pulmonary hypertension, because the, hyperinflated lungs often interfere with the transmission of sounds. So just like it interferes with a good, you don't get a good window for your echo, here you also may get diminution of the breath sounds in the patient with emphysema. So don't depend on the loud P2. But if the loud P2 is there, please don't miss it. Absolutely, ma'am.
That's a query which came to my mind when we are discussing, and I'm really not sure about it. Dr. Saket and Dr. Murali Mohan can just let me know. When you say you are not hearing P2, that means it is at a specified place in the second intercostal space, just parasternal. When patient has a severe COPD or a long-standing COPD and then develops pulmonary hypertension, do you hear P2 in the third space?
Dr. Saket, you want to
I'm
take
not
that?
sure about it. My question itself is hypothetical. It just came to my mind. So I just wanted...
So Dr. Saket, you want to take that?
I have not read anything like that.
Okay. So my take on that, ma'am, is when you say A2 and P2, you're referring to the aortic and pulmonary components of the second sound.
Yes,
it doesn't have to be where they are heard. So you may hear these sounds everywhere. If you hear two, that split sound that you will normally hear in inspiration, the first component is the A2, the second component is the P2. And it's very, very important that you focus on both these and find out which of these components is louder. So if the P2 is loud, it's the later component of the second heart sound that you're hearing more loudly. If you hear it louder outside the pulmonary area, then it is definitely accentuated. It is bound to be a little louder in the pulmonary area.
Thank you.
Thank you all. I think that's been a very, very valuable, refreshing session for me. I've refreshed my knowledge also. Thanks to all of you. And hope we can have many, many more webinars where we take up basic clinical things apart from the new high-fangled stuff that we also like to look at. Thank you to the administrators. Thank you to the CCI team. And a very special thanks to Dr. Saket for not only coming, spending valuable time with us. It's very difficult to get cardiologists to spend so much time with us. Very grateful to you. Absolutely.
Thank you, Dr. Saket, and thank you, Dr. Murali Mohan, for that wonderful moderation.
I would also say the moderation was absolutely spot on. And Chhabra sir was, and everybody was in uniform. I'm honored to be here.
Everybody was, I think. Thank you so much, sir. Thank you, everybody.
Thank you, everybody.
Thank you. Thank you.
Are we off air?